Welcome to the latest installment of the SPARC Seminar Series. I'm Sue Tappan, a member of the SPARC Data and Resource Center. Please join me in welcoming the winners of the Neuromod Prize competition and the program manager of the NIH for the Neuromod Prize project, Sahana Kukke. She's going to dive right in and introduce the speakers, the presentation, and the prize project itself. So Sahana, it's all you.
Thank you so much, Sue, and to the SPARC Seminar Series organizers for including me today. My name is Sahana Kukke, and on behalf of the NIH SPARC Neuromod Prize team, I'm pleased to share and celebrate the winning solutions from the SPARC Neuromod Prize focused on targeted peripheral nerve stimulation. To put today's discussion in context, I'd like to briefly step back and highlight the broader framework that made the Neuromod Prize possible. The NIH Common Fund supports bold, cross-cutting scientific programs designed to catalyze discovery across biomedical and behavioral research. These programs tackle high-impact challenges that benefit from coordination across institutes and disciplines. One powerful example, as many of you have seen firsthand, is SPARC, the Stimulating Peripheral Activity to Relieve Conditions program. With the Common Fund support for SPARC now concluded, the program leaves behind a strong scientific and translational legacy. SPARC catalyzed the development of neuromodulation therapies targeting the nerves that connect the brain to the body. The program advanced new tools and technologies and mapped connections across nerves and organ systems to better understand how peripheral circuits control organ function. SPARC also created the SPARC Portal, an open platform providing datasets, anatomical maps, and predictive simulations to accelerate research across the community, and the portal continues to receive dedicated support beyond the original SPARC program to sustain data sharing and further expand this valuable resource. And importantly, SPARC conducted the Neuromod Prize, a challenge or prize competition to help advance clinical translation of neuromodulation therapies, complementing its broader research investments. With that broader SPARC context in mind, I'd like to focus more specifically on the rationale behind the Neuromod Prize, why we chose a challenge mechanism, and what we hoped it would uniquely enable. Conducting an NIH challenge was a great fit because we were addressing a clearly defined technical bottleneck in neuromodulation, one where engineering and computational approaches could significantly accelerate progress. The prize was intentionally results-driven. Awards were made only when teams met predefined performance criteria. That allowed us to reward validated solutions that advance the SPARC mission in a measurable way. We also recognized that some of the expertise needed to solve neuromodulation challenges existed outside the traditional NIH applicant pool. The prize mechanism enabled us to engage engineers, device developers, data scientists, and other innovators who might not have pursued an R01 style funding. And finally, for focused technical barriers, the challenge structure moved faster than traditional mechanisms. It promoted rapid prototyping, iteration, and milestone achievement, complementing, not replacing, the hypothesis-driven research in the field. The Neuromod Prize was structured in 3 progressive phases to advance solutions toward clinical translation. Phase 1 opened in early 2022 and invited concept papers and development plans. This stage focused on identifying promising ideas and clear technical strategies with an $800,000 prize pool awarded between January and April 2022. From there, 8 teams advanced to Phase 2, where the focus shifted to proof of concept studies. Over summer 2022 to 2023, teams generated experimental data to demonstrate feasibility, supported by a $4 million prize pool. Finally, 4 teams moved into Phase 3, conducting investigational device exemption, or IDE, enabling studies from summer 2023 to 2025. With a $5 million prize pool, this phase supported the rigorous preclinical work necessary to position technologies for regulatory submission and clinical translation. Today, I am pleased to recognize the winners of the SPARC Neuromod Prize. The first place award of $3 million was awarded to the University of Pittsburgh Department of Urology for developing a novel multi-channel implantable device designed for neuromodulation of the pelvic nerves in the lower spine to treat bladder, bowel, and sexual disorders. The second place award of $1.6 million went to Juniper Biomedical for their highly precise micro-implantable neuromodulation system aimed at treating stress urinary incontinence, overactive bladder, and fecal incontinence. Together, these teams exemplify the translational impact the Neuromod Prize was designed to accelerate. It's my pleasure now to turn it over to our winning teams so we can hear directly from them about their innovative work and progress.
You're free to start.
Okay. So first, I want to thank the NIH SPARC program for their leadership and dedicated effort during the last 3 years to organize this neuromod competition. And we're honored to get the first place winner for this competition, and I'm happy to present our study here today. And today I'll focus on dysfunction caused by spinal injury. So I will present a novel multi-channel implantable device for sacral pudendal neuromodulation to treat bladder, bowel, and sexual function. So the neural control of the bladder is very complicated. If you look at it, it's a supraspinal control. The center is in the spinal cord. But if we only think about the function, it's simple. Under normal condition, during urine storage phase, bladder relaxed, the external urethral sphincter, EUS, contracts, holds urine. During voiding, the bladder contracts, but the EUS relaxes, so that a low pressure voiding can happen highly efficiently because the EUS relaxes, urethra open. However, after spinal injury, the coordination between bladder and urethra is lost. During storage phase, the bladder is also contracting because detrusor hyperreflexia, and during voiding, when bladder contracted, EUS also contracting. So that's going to block urine come out of the bladder. We call detrusor sphincter dystonia. In order to completely restore the bladder function of the spinal injury, we have to treat both conditions, detrusor hyperreflexia and detrusor sphincter dystonia. So detrusor hyperreflexia can cause bladder hypertrophy and cause a low bladder storage capacity and frequency incontinence during the urine storage phase. And it also causes multiple transient high frequency intravascular pressure that causes urine frequently back up to the kidney. In the long term, they can cause kidney failure. For the detrusor sphincter dystonia, it causes a large residual volume in the bladder because the urine cannot come out because of the closed sphincter. And they need a daily urethral castration, put the catheter in the bladder, pull urine out 5-8 times a day. Because of that, they can cause a frequent bladder urethral infection, and those infections is a very bad condition for spinal injury people because they are sitting on the chair. And also during voiding have high blood pressure because blood contracting against the urethra. This high pressure going to back up to the kidney in the long term cause kidney failure. So to solve those problems, first we started in the preclinical, we did this preclinical study using chronic spinal injury cat under either anesthetized condition or awake condition with the implant. So this slide shows we discovered pudendal to bladder reflex in chronic spinal injury cat is frequency dependent. At low frequency, like 3, 5, 7 hertz, it can completely inhibit the bladder overactivity, treat hyperreflexia, makes bladder quiet during storage, and make bladder capacity bigger. When voiding is intended, this stimulation can be switched from 5 Hz to 20, 30 Hz. This higher frequency is excitatory reflex. It can cause blood contraction as shown here, even at a very low blood volume. So in summary, the low frequency 3 to 7 Hz pudendal nerve stimulation can inhibit bladder activity, increase blood capacity, can be used to treat the detrusor hyperreflexia. And the 30, 20 Hz can be used to drive blood contraction, but the call activation of the sphincter, the DSD, still is a problem. So we still have to fix the DSD issue before we can induce contraction. Otherwise, the urine going back up to the kidney. So in order to block the relaxed sphincter during voiding, we investigated the pudendal nerve block using 6 to 10 kilohertz to temporarily relax EUS. This is experiment set up in the cat under anesthesia. We put the catheter into the urethra, slowly perfuse the urethra. Once the EUS contracted, the perfusion pressure going to be back up to showing the EUS is closed, urethra is closed, right? So this mimics the DSD. So in order to show we can temporarily block the pudendal nerve, relax the EUS, we put 2 electrodes on the pudendal nerve, stimulation A and B. Stimulation B going to be stimulated at 40 Hz continuously. That's going to drive the EUS contraction. You can see the pressure, perfusion pressure going to be increased. And during this stimulation B, if we apply 7 kilohertz to stimulation A, whenever we apply this kilohertz, we see the pressure drop, right? So that indicates that we can temporarily block. I'm saying that temporarily because the block is reversible. Once we turn off the kilohertz, the pressure comes back again. So the neural conduction happens again, EUS contraction again. We need this block to be temporarily, can be easily reversible because right after voiding, we need the pudendal nerve to be functional again so that it can close up the urethra and hold the urine during urine storage. So in order to further prove this is local nerve block instead of muscle fatigue, instead of EUS muscle fatigue caused by this kilohertz stimulation, because we don't like the muscle fatigue, because muscle fatigue can work temporarily for, let's say, in clinical application, it can work in a month, maybe half a year. But as fatigue continues to apply every day, the EUS muscle become more and more fatigue resistant, the system eventually going to be fall down. We are looking for a system can be working for years instead of weeks, days, or months, right? So we want to make sure there's a real local nerve block. How we do that? We did this way. We put the stimulation B driving the EUS contraction on the central side of the blocking side. That way, when we apply kilohertz, we can see the block. Once we move the driving electrode to the distal side, to the blocking stimulation A, but then we apply kilohertz, it cannot happen. The block cannot happen. That indicates it's a true nerve block, not muscle fatigue, because if the muscle fatigue by the kilohertz, no matter where we put the driving electrode, either central or distal, the block should always happen because it's fatiguing muscle, right? So this is a true nerve block, quickly reversible. So in summary, high frequency 6 to 10 kilohertz biphasic stimulation can block pudendal nerve and reduce urethral resistance. The question is, can we use this block to treat DSD and combine with the 30 Hz pudendal nerve stimulation driving blood contraction to induce highly efficient low pressure voiding? We want low pressure voiding, not high pressure, because high pressure voiding can cause kidney damage in the long term. So here shows our strategy. So we're going to restore bladder function, both the storage function and the nutrition and the voiding function of the spinal injury by implanting 3 electrodes on both sides of the pudendal nerve. The electrode number one, going to deliver 5 Hz stimulation to inhibit bladder during storage phase to treat the detrusor hyperreflexia, prevent frequent incontinence to happen. When the bladder is full, we're going to switch the 5 Hz to 30 Hz to drive a bladder contraction for voiding. However, before we switch it driving bladder contraction, we must to relax the sphincter, the EOS first, before you drive bladder. Otherwise, high bladder pressure going to happen. Right? That bad goes kidney. So we're going to apply 10 kilohertz to both sides of pudendal nerve on electrode number 2 and 3 to block the nerve conduction temporarily. Then we apply the 30 Hz drive bladder. That way, the EOS is relaxed, the block totally prevent the DSD to happen, and the bladder contraction can drive the urine out of the bladder at low pressure and very efficiently. So this is our strategy. To prove this strategy work, we first tested in chronic spinal cord injury cat under anesthesia. Here shows if we just infuse bladder in the chronic spinal injury animal, the bladder, once bladder is full, they can generating a reflex, spinal reflex contraction, but that contraction can only release a little bit urine, very inefficient. If we only apply the 30 Hz pudendal nerve stimulation, we can induce huge bladder contraction, more than 50 cm water. So, but there's no urine release during the stimulation. Only have a little bit of urine release at the end of stimulation. That's because when the stimulation is off, the striated muscle EOS relax first, faster than the smooth muscles bladder. So that blood pressure can drive a little bit urine comes out. So that's not good also. So if we combine the 30 Hz with kilohertz block, we apply the kilohertz block bilaterally to both pudendal nerve on left and right side with 10 kilohertz. Then we apply the 30 Hz to drive bladder. Now we see a huge amount of urine comes out, but the blood pressure actually is lower. It's only less than 50 cm water. Why? Because once the EOS relaxed, the urethra open, the pressure cannot go higher because urine starting to flow out. This is an open system. It's not a closed system anymore. So this proves the under anesthesia by urodynamic showing this pudendal nerve block and stimulation in combination can achieve a low pressure efficient voiding. Here's a summary slide. So shows on average, if we only use 30 Hz, they generate about 80 cm water, but very inefficient voiding because urethra is not open, right? DSD. So, but if we combine 30 Hz and kilohertz block, now we have very high efficient, almost 90% voiding efficiency, but we only need on average 40 cm water. So then we test this idea further by implant a wireless control, wireless chargeable stimulator into the awake chronic spinal injury cats. Here shows how we do this. In those cats, because they have complete spinal injury, they don't have sensation below the transaxle spinal cord. So the low body have no sensation. We can do awake CMG. So we can put a catheter into the bladder and close the bladder neck with a balloon and do this measure blood pressure change under awake condition. So here shows by measuring blood condition, by measuring blood pressure at different blood volume, we can adjust the stimulation A on the electrode number 1, the stimulation 30 Hz stimulation, to be a not so strong, not so weak intensity to generating just below 50 cm water pressure, contraction pressure, all right? So based on urodynamic, if with a closed outlet, closed urethra, this stimulation can only generating less than 50 cm water. When we apply this block, open up the relax the urethra, so when the voiding happens, urethra open, then this stimulation not going to be generating more than 50 cm water. So we know when voiding happens in those cats, it's a low pressure. So here we test 6 cats with the implant. On 5 of them, we achieve almost 90–80% voiding efficiency. In one of cats, cat number 2, we have at least 80% voiding efficiency. So we be able to generating low pressure voiding in chronic spinal cord injury cat under weak condition daily. This shows the summary of 12-week testing on this cat. We achieved during all the 12 weeks almost 90%, 98, 100% voiding efficiency, and the urine come out smoothly on the steady stream. FDA requires us to test the cat, the implant in a 12-week period. So this is what we did. In addition to the voiding function, we also shows in awake chronic spinal injury cat, by stimulating the pudendal nerve at low frequency, 5 Hz, we can completely inhibit those non-voiding contractions. That is the indication of bladder hyperreflexia, prevent leakage, and significantly increase the bladder capacity. So this part of my presentation, we already successfully tested our implant in awake chronic spinal injury animal to show low frequency can inhibit bladder during storage phase, prevent frequent incontinence. When voiding happens, by stimulating and blocking the pudendal nerve together, we'll be able to achieve high efficient voiding with very low blood pressure. In addition to the bladder function, we also show in chronic spinal injury animal under awake condition, the pudendal nerve stimulation. If we apply the intermittently 5 seconds on, 5 seconds off, we can induce a rhythmic vaginal contraction to improve the female sexual function, or tonic contraction, all depending on how we program the stimulator. More importantly, we show in this awake animal on this chronic spinal injury on the weak condition, with pudendal nerve stimulation induced rhythmic contraction of vagina can significantly increase the vaginal lubrication and the wetness. Here shows a more than doubled increase the lubrication. And the vaginal wetness is measured by a small piece of cotton inserted in the vagina for 10 minutes, with stimulation or without stimulation. So we measure that way. So in addition for those, the sexual function, female sexual function, and the bladder function, we also investigate the defecation, the bowel function here. This slide shows under anesthesia in the cat, the 2 balloons inserted into the colon to measure the colon contraction. And then at the same time, we stimulating the sacral S1 to 3 roots individually with a different frequency. We found out 7 Hz optimal frequency when we apply to the sacral S2 roots to induce big and large colon contraction that's useful for either defecation or facilitating the colonic transit. This slide here also shows if we apply this 7 Hz S2 root stimulation continuously, we can induce defecation. Three marble in the rectal area was evacuated. 2 of them come out first, the third one come out halfway here. So we can achieve more than 70%, 60-70% empty of the rectum area by continuous stimulation as to root at 7 Hz. By comparing the continuous stimulation with intermittent 1 minute on, 1 minute off stimulation, we see that although continuous stimulation is effective to induce defecation, it can have a significant fatigue, cause significant fatigue. But the intermittent stimulation, 1 second on, 1 minute on, 1 minute off, can induce a rhythmic, we call the minute wave in the colon. This mimics a natural 1 minute wave that happening in the colon during the colonic transit to move the content in the colon from proximal to distal to get ready for the defecation. So we would like to, we believe this 1 minute wave induced by our stimulation can also achieve the function for colonic transit to happen. So we did to prove our hypothesis, we did a further more study in the cat under anesthesia. Here, so 3 marble was inserted into the colon in the proximal, middle, and distal colon. If we wait there for an hour, for 60 minutes, nothing going to happen. No colonic transit can happen. However, if we're stimulating the sacral S2 roots with 1 minute on, 1 minute off intermittently for 60 minutes, at the end of the stimulation, we see the marble was transferred from proximal side to the distal side, some of them into the rectal. So in order to quantify this visual study, we can visually see it. In order to quantify this, we calculated the colonic score. The colonic score is the sum of all three marble scores. So we see that 60 minutes sacral roots intermittent stimulation can significantly reduce the score, colonic score, from 6 to about 3. So reduction of the score indicates the colonic transit from the proximal to the distal. Okay, so in addition, for the bladder and bowel and the female sexual function, we also studied the penile erection in the male cat. This slide shows a needle, 20 gauge needle inserted into the penis to measure penile pressure. Then we're stimulating sacral S1 to 3 roots at different frequency. We discovered at one sacral S1 or S2 root at 30 Hertz, not the low frequency like 7 Hertz for the defecation function, but here we need 30 Hertz. 7 Hertz doesn't work for the penile erection. So 30 Hertz can induce sustained higher than 100 centimeter water penile pressure. And above 100 centimeter water pressure can induce sustained penile erection. And in the cat, we also be able to observe the erection to happen even without the needle. We can see the actual erection to happen by video tapping. I didn't show the video here, but the pressure is high enough and sustainable. Okay, based on our preclinical animal study, we developed an implantable sacropudendal neuromodulation device. It can receive 4 leads. Each lead can have 8 independent stimulation channels. So we're going to implant 3 leads to the bilateral pudendal nerve to restore bladder function, both storage and voiding function for the bladder after spinal injury by kilohertz block and 5 or 30 hertz stimulation. Meantime, this pudendal nerve stimulation electrodes can also be used to improve the female sexual function by increasing the vaginal lubrication. Also, the 4th leads can be inserted into the sacral as targeting the sacral S2 roots. At the low frequency 7 Hertz, it can be used to facilitating the colonic transit and also induce defecation by continuous stimulation there. When for the male patient, this sacral root stimulation can be switched from 7 Hertz to 30 Hertz to induce penile erection. So this is our strategy. This is what we developed. Okay, thank you very much.
I'm David Constantine, co-founder and CEO of Juniper Biomedical. I'm going to walk through this venture and what we've done with the support of the Neuromod Prize a little differently. I'm going to talk about venture development and how we achieve our principal objective of impact. So first of all, I want to thank the SPARC program and the Neuromod Prize acting as a catalyst for our company and for other initiatives. It's a really fantastic program and really well timed, I think, with the evolution in what we can do with neuromodulation technologies. What I'm going to do is I'm going to give you a 50,000-foot view of Juniper Biomedical. I'm going to talk through what we're doing in our first application, at a high level, how it works. I'm not planning on digging in and doing a scientific review. I'm going to talk a lot about how we build the venture to ultimately have a pronounced clinical impact. I'm going to talk about the translational efforts that we conducted. how the Neuromod Prize and MedTech Innovator acted as catalysts for the company, and the pursuit to develop the venture. And this is all as an effort that is you're sort of driving the car while you build it. That none of this ends up being linear. You have to pursue all avenues that influence the development of the company and development of the technology and the clinical application, in parallel, with making adjustments along the way. So start with, let's just talk about urinary incontinence. Urinary incontinence, I think for people doesn't register as a profound effect, because most people who suffer from urinary incontinence don't talk about it. They suffer in silence. They manage the disease alone, and it's a really big deal. And I didn't even realize when we first started the venture, how many people around me, adjacent to me, family members, close friends, suffered from this. And it's because they don't talk about it. Of course, when you're doing something like what we're doing, people come out of the woodworks and start talking about what they've been dealing with for years. So that I think is a really important starting point, that it's a huge, huge impact on people's lives. So high level, about 78 million women alone, just looking at the female population, women in the United States alone suffer from either urge or stress incontinence. And I'm sure that a large group in the audience here recognizes what these are. But for clarity, urge is the type where you may race to the bathroom 18, 20 times a day and leak on the way. Stress is the type where a laugh, cough, or sneeze causes a leak. But almost 2/3 of these patients have both urge and stress, called mixed incontinence. And there's no solution in the market today that actually treats mixed incontinence. So what ends up happening is that patients will present with mixed symptoms, and doctors will have to, this is urologists and urogynecologists, tease out the predominant symptom, either urge or stress, because that's all they can treat, one or the other. And the gold standard options that are offered to patients are really not attractive to them. When you ask patients if they want these solutions, a lot of them run the other way. Over 90% of good candidates, not the top of the funnel, 78 million, good candidates don't receive these. They don't want them. So you have a three-tiered problem when it comes to mixed incontinence. Stress and urge are treated separately. Fundamentally, that's more challenging. The diagnostic burden associated with parsing predominance that can be cyclic and misdirected, and lead to multiple treatments, is a challenge. And it doesn't make anybody, and from a business perspective, it's not like that's a pervasive driver of business thing. It's just a challenge. And then ultimately that options that are available are unattractive to patients, so they're not getting treated. We address all three of these, and we've done that very deliberately. So we have a solution that treats both urge and stress symptoms separately or together as a full solution for mixed incontinence. And this is done with a really unique neuromodulation micro implant that we've developed. And what you're seeing here is actually we've iterated upon even more, but has been developed over many years, gone through cycles of innovation, but in its end state is a very, very small implant. It's about half the size of a US dime. And it's delivered to provide a therapy that is fundamentally different in terms of its approach. So if you think about peripheral neuromodulation, most neuromodulation, if you think about the periphery as a tree for simplicity, most neuromodulation is stimulating the trunk of the tree, large multifascicular nerves, large implants, big batteries, and the imprecision associated with that leads to patient-to-patient variability, side effects, and there's just only so much refinement that you can do with that. It's limited, it's inherently limited in its nature. What we've done is flip the script on this and go way down on a distal branch. We couple directly to the nerve with a specially designed atraumatic coupling mechanism that goes on really quickly and very securely and doesn't hurt the nerve. And it allows us to deliver a very low power, highly precise therapy. This allows us to go after novel nerve targets, novel applications, and deliver therapy profiles that are different than you would from a proximal nerve. The mechanisms you can induce are different. And so with this, for mixed incontinence, we have developed a minimally invasive access procedure that is allowing us to couple this device to a novel distal nerve target. A proprietary nerve target in the lower pelvis is directly connected to the device. So there's no wire lead placement, the potential for lead migration, challenges as a result of encapsulation of the leads. It presents a very different paradigm. And in the first generation of the device, we anticipate over a 10-year battery life, which I think is well suited for patient adoption in that context. Now, this implant delivers a therapy that has two effects. So one implant, one surgical procedure, one nerve, but it has two effects. One is an afferent mechanism not dissimilar from what you see in sacral or tibial nerve stimulation that's essentially telling the brain to tell the bladder to calm down. And that mechanistically, I don't think is beyond the understanding of what's done today. The other mechanism is actually a remodeling mechanism that restores neuromuscular closure mechanisms of the urethra. And that effect, we've spent a tremendous amount of time studying and making sure that we really understand. And I'll get to that in a second. But as a product profile, this therapy, this is a daily therapy, it's not a continuous stimulation, is delivered automatically. So the patient doesn't have to do anything on a day-to-day basis to receive therapy. And that's important because when we did research, we originally had a wirelessly powered device, and it was the size of a freckle. It was very, very small. But what we deduced is that patients, doctors, strategic corporations that would be interested in us, venture, they did not want a compliance burden, an adherence burden. They didn't want to ask the patient to do something in order to receive therapy. So we adjusted the profile, and it's much more resonant to have that automatic therapy profile. And with that, we're able to deliver therapy that treats both urge and stress symptoms. We can really take the burden out of the patient's lives. That idea of having a condition that they have to manage dissipates. And that's a huge impact on the psychology and ability for people to re-engage in life from this otherwise fairly debilitating condition. So with that, I'm going to just talk about, that's the overview. I think as a company and as a team, we come together around one central idea, and that is that we wanted to have a clinical impact, a commercial impact on patient care. And to do that, you need to build a business. And that exercise is non-trivial, and aligning research with that is non-trivial. And it's a step that's, I think, often misunderstood. So when we approach it, we first start by evaluating, is there a business here? And I mean this literally, can we kill it? We tried very hard to identify where this would fall down in patient appeal, physician appeal, market positioning, defensibility. We really look for that. But the first thing you want to look for is there a place in the market where the differentiation here adds value? So if you look at the treatment of urinary incontinence today, and you look at it from a perspective of invasiveness and efficacy, we have a really different proposition. Not only that we can treat mixed, but that we have this spot where we anticipate a very high efficacy profile for both stress and urge characteristics, but offer a minimally invasive strategy. It really puts us in a different position. If you look at the advanced therapies, the neuromodulation therapies, and in the context of stress, suburethral slings, we offer a very different profile of a product. And you can look at it this way in terms of the nature of the treatment, where we're actually restoring a natural function, not a mechanical augmentation, that we don't suffer from some of the challenges associated with some of the execution of the delivery of therapies and some of the other paradigms. That from a complications perspective, we don't anticipate some of the challenges that are associated with other stimulation approaches, and certainly not from the vantage point of slings. It's a very different solution. We're looking at it from the vantage point of its clinical profile, the implant itself, and the therapy profile and mechanisms. It's very different. And so the next thing you go through is, does that matter? Does anyone care about that? And talking with the clinicians, what you look for at this phase is directionality. Are we pointed in the right direction? If we refine this pathway, is there a market opportunity? And we got was something very different. We got a level of alacrity and interest that was not just directional. It was pronounced. It was clear that this was a big deal to treat mixed incontinence and to do it with a profile of a product like this. It really, really has the potential to change the game for patient care, for the physicians, for the patients. There's a alignment as a value proposition to each of the major stakeholders. So if we think about it now as a sequence, and it's not a sequence, it's a nonlinear process, but that at that point, then you want to translate this. We look at it from a research and product perspective. Our company, I think, very often when industry gets hold of technology that's gone through rigorous research cycles, it's how fast can we possibly get this through the FDA and into market? We didn't approach it that way. What we approached it with, we took it out early. And the reason we wanted to do that was we wanted to do our research with the endpoint in mind, an understanding of downstream risk, downstream market characteristics, and make sure that our research made sense to inform that. So that exercise is not small. There's a lot of research conducted on several hundred specimens in large animal, small animal. And from this, I'm just giving a global overview. We deduced that we could very consistently affect bladder urge symptoms, that we very consistently actually repair dysfunction and enhance reflex closure mechanisms of the urethra, really pronounced ways. That we then went through the exercise of trying to understand the knobs and levers and why this effect is seen. And the understanding of the mechanisms of action that we conducted offered great insight into why that works well and that it works really well. But that's all great. If you can't get the procedure in there, if you can't get the device in human easily, it's not going to work in the market. So we developed a surgical procedure originally in cadavers, a lot of cadavers, and then in a live clinical study. And those exercises allowed us to refine our targeting, refine the stimulation parameters, and also confirm that the mechanistic effects that we see in animal are consistent with what we see in human. And that confidence really positions the translation toward the ability to have an impact in the market. So all during this time, we're also refining product. So what you see here is an end state product. It's a clinical design, and we use this in many of the study work. And we've iterated upon this as well, based on the insights from that work. But leading up to this were hundreds of working devices that we evaluated. And we had to evaluate how they would position to the nerve, how they coupled, the stimulation profile. There's a whole bundle of progressive reduction to this more evolved clinical implant design. And in order to do that, we needed a catalyst. So we raised private capital from some deeply knowledgeable domain experts, entrepreneurs who are in this space, as well as the Neuromod Prize. The Neuromod Prize acting as a catalyst to conduct and evaluate rigorously that translational work was a key characteristic of our development. The other thing we needed to do is just get a little loud, is to create some visibility, because that's part of the process of building these ventures. So the combination of the Neuromod Prize and also we were a grand prize finalist, which is really the win. I mean, just being on stage in that context out of 1,400 companies is a win. that offered a tremendous amount of visibility and connectivity for the venture to then build out. So then at that point, you're talking about venture development. To make an investable company, to build out the venture to then reach patients. The number one thing, without question, and people say this all the time, and I think it's treated sort of like a blog title. It's very trivial, like, oh yeah, team is the most important thing. Team is the most important thing, without question. We would not be able to have done this in a lean, high volume research way that we did without the type of team that we had. Everyone has 20 to 30 years of experience. I'm going to get back to that slide in a second. Specifically in this domain, large multinational corporate experience and startup experience to bring together a rapid ability to assess technical and product and market and clinical characteristics that we needed to refine. We were able to conduct and pivot as we needed to with any insight very, very quickly. So from team, we're building product, we're identifying differentiation points, we're going through a rigorous regulatory strategy. This is a PMA product, which means you have to do clinical trials and it's an electronic implant. There's no way around that. And frankly, I'll take that over a de novo any day because it's concrete. You have a moat you create when you get into market. It's what, from my vantage point, positions us well in the market. A lot of people will punt on talking about how they're going to get paid because it's a business. It has to actually generate revenue in a way that's consistent and supports the care paradigm. So going through the exercise of understanding coding, coverage, and payment is an enormous undertaking because that's a spaghetti mess of topics that all come together to inform how the venture is going to play out. And it's a moving target because policies change. So keeping up on that and using that work to inform the commercial strategy is imperative because it has an effect on what we do now. Our clinical study designs, you could very easily just look at the FDA and say, okay, what does the FDA want? Go talk to them, which we did, and gain insight into what we can do to get over that next hurdle. The problem with that is when you get into market and you're pursuing the stakeholders of coding, coverage, and payment, they see it differently. They may look at the measures differently. They may look at the way that you conducted studies or where you conducted studies differently. The requirements may be fundamentally different. So looking at all those downstream efforts, or those downstream risks rather, to inform the immediate effort, which tracks back to products too. All of this comes back. So you end up having to do a whole lot of downstream stuff like you're much further along as a venture to inform what you're doing today. And we did that. And I think it's really, really important, back when you're doing the original research, to be thinking about how does this play out? If you want to have an impact on patient care, if you want to have an impact with the technology in the clinic, to be thinking about these variables very, very early. So we went through all of these exercises, built out this team early. These are dedicated team members. It's a phenomenal team. I love this team. And now we're at a point, thanks to the Neuromod Prize and thanks to the efforts that we've taken over the last 6.5 years of developing the venture, where we're in a sprint through the pilot studies that will position us for the IDE for a US pivotal. And to architect that meant going through the product development, the risk reduction for the clinic, building out rigorous plans that were informed by all these downstream factors, making sure that we had the right team and the right team evolution plan, and that we understood the market well enough to really support the thesis and the viability of the business in the long run. So take-home messages. It is requisite to build a sustainable business in order to have the strongest avenue for impact. So I think that's an important takeaway. The second is that you're always driving the car while you build it. This is an incredibly nonlinear process. It will continue to be through market. And I think if you go in knowing that and recognize that you're going to be talking about things in pieces to a level of depth that you only makes sense today, to then go back to it again and redo it. All of the market stuff you redo and redo and redo. is part of the game. Drive the car while you build it. That the downstream risks are crucial to incorporate into the plans for the company or the research early, very early. The more understanding you have of the downstream stuff, the better. And finally, the team is everything. Team is absolutely everything. And at this early stage, it's really, really personal. It's something I would talk about offline a lot. That the team that you put together, it is a marriage. It is a marriage because it's not just a job. You're getting into it to have a really big impact. You're taking a lot of risk, or at least perceived risk, in pursuing these things. And you gotta know that you can trust one another, you can argue, you can debate, and come out the other side feeling better about the relationship that you have with the team you're working with. So it's Juniper Biomedical in a nutshell, our experience thus far. Thank you so much to the Neuromod Prize, to the SPARC program, to NIH for acting as a tremendous catalyst for us.
Thank you very much, David and Ty. I'm going to turn things over to the entire group and invite people to submit any questions that they have in the question window, and let's have a discussion about how things are presented here. So offer up your questions, and Sahana, if you'd like to moderate, I'd be happy to have you do so.
Well, one thing that maybe just to get us started, we do only have 6 minutes, so we'll make it quick. But maybe I'll ask both of the winners. So we saw very different presentations today. Ty, yours was more technical and scientific, and then David, you provided more of your insights for Juniper as a venture. And I wonder, I don't know exactly who is in the audience today and what their perspectives are, like where they're coming from and approaching neuromodulation. And both of you have shared kind of the critical element of Neuromod Prize in your product right now. Are there other sources that you can point to earlier on in the process that brought you here? I'm asking that because we've also talked differently about this trajectory. This is for bioelectronic medicine. It's been moving for a while, and how to get to the next step. So kind of if there is any insights you have on critical growth moments and where that catalyst came from outside of this prize, that might be interesting for some people in the audience who are looking for those steps in their own work and how to get to be at this place, this more mature place where you are now. Any thoughts you have on that?
I definitely do, and I know Ty does too, because they've built up a commercial pathway as well, as I understand it from just our conversation. But I think that working, my co-founder is very much an academic researcher, and so I think that the dance that we had early on was to recognize what do we need to do to make this venture investable. And when I say venture investable, I mean more broadly than venture capital, because venture capital in the past few decades has really shifted to align with later stage pursuits. And they'll even call it early stage, but early stage is like post-clinical at FDA approval in many cases, and you're like, really? So how do people do things? And it's a combination of that which NIH and specifically SPARC and the Neuromod Prize provide, that SBIR, STTR programs provide, that ARPA-H provides, that the NSF provides as catalysts for translation. For business, for impact, taking that rigorous science that everybody's done, that Ty does in his lab, and actually enable patients to use it. And there are gaps, and I think whether you're, well, speak to two things. One is those gaps are filled with different interests. So angel investors, angel groups, family offices, and they may have a different outlook in terms of what they're looking for, their understanding and acumen of the details of some of the ventures, where the venture capitalists may have a very, very rigorous background in a particular area and know a lot. You may be talking to an angel who's made their money in something that's non-scientific, and you're talking to them in a different language. So taking the research, and this is Mario and I early on, taking the research and saying, how do we reduce this to the most meaningful, clear, validated pursuit as a venture? Building out that profile of what is venture investable, all of those characteristics, the plans, the regulatory, how you're going to get paid, the product positioning, all that stuff. It is far more important than you'd think. It's not just sexy research. Tai.
Yeah, I want to add something as academic research here, because a lot of my colleagues who work in the lab, they just publish paper, they don't file patent. So I want to say, if I didn't file this patent 10 years ago, there's no commercial. I want to emphasize this is, if only when you file patent application as a patent after the federal government funding runs out, when the first developed from the lab, then you give the opportunity for venture capital, for the private investment come in. Without any IP protection, venture capital not going to come in. Your technology is not going to anywhere. That's what I want to say. That's what I learned.
Well, in Tai, we had to do some licensing as part of our IP portfolio.
Yeah,
I'm sure you went through that exercise, and that's non-trivial and different by institution. So now
yeah,
that
but many scientists in the lab, they don't realize. They
Yeah.
just publish it, that's it, right? So
Yeah.
they don't realize how important it is.
Yeah.
Thank you. That's great. Well, I love that take-home message right at 12 o'clock. I didn't see any other questions come in, so I guess I will wrap it up there. Sue, was there anything else you wanted to add before we closed?
I think that I want to congratulate the winners again. Thank all of you for your time and willingness to share your insights with the community. And you can always go to the SPARC portal if you'd like to explore open data relating to autonomic control and peripheral control.